Hi, everyone, and welcome to the Parkinson's Foundation Greater Illinois Chapter PD Sleep and Me program. My name is Jessica Barch, and I'm the Community Program Manager of the Greater Illinois Chapter. Before we get started today, I wanted to say a few things. First and foremost, I want to thank all of you for joining us today. Whether you've attended our programming in the past and it's been in person, or maybe you've been joining us for our virtual programs, or maybe this is the first program, we're so happy that you're here and we welcome you. In addition, I wanted to share some of our wonderful resources. One I want to specifically highlight today is our sleep book. So this sleep book talks about the challenges that some people with Parkinson's may face, and it talks about the challenges of sleep and ways to cope with that. In addition to the sleep book, we have many other books. A very popular one is called our Frequently Asked Questions book. We have a great book that is called Living Your Best Life. And then we also have some books, here's an example, that talk about the symptoms that are non-motor, so non-movement symptoms, cognition being one of the examples. We also have this great book that is specific to care partners of people with Parkinson's called Caring and Coping. In addition to these books, we have a very important resource called our Aware and Care Kit. This is also known as our hospitalization kit. So within this kit is everything you need to communicate with your healthcare team while in a hospital setting about the importance of getting your medication on time. In addition, there is information that talks about medications that are safe and not safe for people with Parkinson's. In addition to these resources, we have a wonderful podcast called Substantial Matters, and we also have a great website called Parkinson.org. On Parkinson.org, you can explore that. There's so many topics to explore and so much information there. Last but not least, we have a wonderful helpline that is staffed by Parkinson's specialists. So thank you for taking the time to listen to me today, and now we will start our program. And now it is my pleasure to introduce my first speaker, Dawn Weberg. Dawn is owner of Dragonfly Meditation and Wellness. She is a certified meditation instructor, mindfulness teacher, Reiki master, and Spring Forest Qigong practice group leader. Her love of mindfulness and meditation has led to her sharing her knowledge with others through corporate talks and guided meditation sessions. She loves incorporating mindfulness into all aspects of her life. Sharing meditation is one of her greatest loves, along with visualization based on nature and positive affirmations. Welcome, Dawn, and thank you so much for joining us today. Okay. You know, guys, in the meantime, right now, what we're going to do is we are going to bring in our second speaker, and we're going to kind of switch them right now. So, Dr. Blindauer, we are going to have you present first. We will still have time for our Q&A. And then we will just keep going on here, rolling with it. All right. All right, Dr. Blindauer, are you able to share your screen? Wonderful, we're starting to see a screen share. Perfect. Thank you, Dr. Blindauer. Everyone, I'd love to tell you a little bit introduce Dr. Blindauer, who we're so excited to have here with us today. So, Dr. Blindauer is a professor of neurology at the Medical College of Wisconsin. She specializes in the care of patients with Parkinson's disease and other movement disorders. She was born and raised in Sheboygan, Wisconsin, and she earned her medical degree and completed her neurology residency at the Medical College of Wisconsin. She then went on to complete a fellowship in movement disorders and experimental therapeutics at the University of Rochester in New York in 1999. She joined the faculty of the Medical College of Wisconsin and started the Parkinson's disease and movement disorders program there in August of 1999. She has served as the director of this program for over 20 years. Her research interests include studying new treatments for people with PD with the goal of finding new therapies that may improve their symptoms, quality of life, and slow the progression of the disease. Welcome, Dr. Blindauer. We're so happy to have you join us today.
Oh, thank you, Jess, for that wonderful introduction. I'm very, very happy to be here and to be able to provide this education event. I have to admit, it's a little strange for me talking to my computer screen and just not seeing all of the faces of the people that are usually in the audience. So I really do miss that, but I'm glad we're at least finding a different way of reaching out and bringing information to our patients. So again, I'm really happy to be here. And hopefully I don't have any technical difficulties, but we'll see how this goes. So the objectives of my talk include understanding what are the most common sleep disorders experienced by people who have Parkinson's. And we want to learn what affects the Parkinson's symptoms or medication and other health problems might all have on our quality of sleep, and then learn about sleep hygiene and other strategies to help improve our sleep quality. So I'd like to start with, well, what do we know? We know that Parkinson's disease is a movement disorder. We think about the resting tremor, the bradykinesia, the rigidity and the postural instability, but Parkinson's is so much more than just a movement disorder. And we always have to keep that in mind when we're providing good care for our patients. So why the movement disorder happens is because of a loss of the dopamine neurons in the area of the brainstem called the midbrain. I hope my arrow is working, but I'm not 100% sure. The symptoms of Parkinson's result because of a deficiency in the neurochemical dopamine. And it's thought we have to lose about 70 to 80% of those nerve cells in the midbrain before we will start to have the symptoms of Parkinson's. So there's a lot of changes occurring in the brain behind the scenes before a person ever knows they have Parkinson's. Now these are the classic slides, showing the pathology in Parkinson's. So it's a slice of the midbrain, the area that I had the arrow pointing to, and the top picture is a picture of a normal section, and that's the area of the substantia nigra that contains the dopamine nerve cells, and the section below is in a patient with Parkinson's, and that area is faded out because of the loss of the nerve cells. And just to the right, we're looking under the microscope, and those dark sort of irregular shaped structures are those dopamine nerve cells, and they're very dark because they have the pigment melanin. And that section right below is a section from a patient with Parkinson's, and so many of those dopamine neurons have been lost. And then finally, the picture way off on the right is the pathological hallmark of Parkinson's, and that is the Lewy body. It's that little red circle. That's a collection of abnormal proteins, including alpha-synuclein, that when they clump up inside the nerve cell, it's thought to be one of the reasons why the nerve cells are dying off. So Parkinson's has many non-motor signs and symptoms that can include mood disorders like depression and anxiety, cognitive changes like dementia, sensory symptoms and pain, constipation, bladder dysfunction that can include urgency, frequency, and incontinence, fatigue, and then finally sleep disorders, which is what the bulk of my talk will be about. So then the question would be, well, why do we see all these non-motor symptoms? And the answer is that pathology in the brain goes far beyond that little area in the midbrain that's just containing the dopamine nerve cells. So in this other section of the brain, I'm pointing to other areas. So below the midbrain is the pons and the medulla, which is lower parts of the brainstem that are containing nerve cells that control sleep and control mood. So when there's Lewy body pathology in those areas, that's when patients will experience the sleep and the mood disorders. And the rest of the brain, called the cortex, when Lewy bodies occur in those locations, that's when we might see the cognitive changes, or in advanced stages could progress to dementia. So is sleep really a problem in people with Parkinson's? And the answer is definitely yes. So sleep disorders are common, and it can affect as little as 50% or as many as 98% of people with Parkinson's. Now, having a problem with sleep can negatively impact one's quality of life, just like those motor symptoms. Poor sleep will worsen a person's Parkinson's disease, because when we sleep, our brain will make more dopamine. When we don't sleep, the dopamine deficiency that a person with Parkinson's already had is made even worse. And then, of course, poor sleep has other health implications. Now, there's a long list of sleep disorders in Parkinson's, and I'm going to try to run through all of those in the next 30 to 40 minutes or so. So in people with PD, they may have insomnia, parasomnias, which is like sleepwalking, REM behavior disorder, restless leg syndrome, periodic limb movements of sleep, nocturnal myoclonus, vivid dreams, sleep apnea, and then excessive daytime sleepiness. So before we delve into the sleep problems in Parkinson's, we need to better understand what is normal sleep. So normal sleep is a process of the brain cycling through different stages throughout the night. And there's two main stages of sleep. One is non-REM, and that stands for non-rapid eye movement sleep. And it's divided into two different types. One is a light sleep when you're just dozing off, and the other is the deep sleep, that restorative sleep that makes us feel refreshed in the morning. And this non-REM sleep takes about 80% of our night's worth of rest. Now, REM sleep stands for rapid eye movement sleep. And this is the part of our sleep state when we are dreaming. So it's a much more active part of the sleep cycle. It only encompasses about 20% of our sleep and has the longest duration in the last third of the night. So that's why sleep disorders that occur during dreaming are occurring more like 2, 3, or 4 a.m. in the morning. So during sleep, our body will cycle between the non-REM and the REM sleep. So I have a diagram here that's showing how we cycle through sleep. So we start with being awake, and then if we follow the up and down pattern on the bottom part of the slide, we drift into the lighter sleep. We make it into, excuse me, the deep sleep, which is the kind of pinkish highlight, and then you go back up into a lighter sleep, which is the dream sleep and REM sleep. And you can see throughout the evening how we're cycling from light sleep, deep sleep, and then later in the evening we're cycling between the dream sleep and just the lighter sleep. So this is what our brain is doing all night long. So it's a rather active, more so than a passive process. Now, just getting older can actually change our sleep. So as we get older, the quality of our sleep declines, unfortunately. We are more likely to wake up several times through the night. Our sleep efficiency is reduced. So only 70 to 80% of the time in bed is actually having good quality sleep. We might be more inclined to nap during the day. We have an increase in the stage 1 or the lighter sleep, and a reduced amount of the stage 3 or the deeper sleep. So overall sleep is less restorative. Now the REM sleep portion, or the dream sleep, remains relatively unchanged. So excuse me, I'm just going to grab a drink of water. Okay, so the first topic we'll cover is insomnia. And this is typically a picture of me. I'm not a good sleeper. I'm counting sheep, having trouble falling asleep. Excuse me. There's different types of insomnia. So there's the sleep onset, where it's hard to fall asleep. So you go to bed and you're lying there for a long period of time. You can't get yourself to drift off to sleep. And then in contrast is the sleep maintenance type of insomnia. Excuse me, where you fall asleep okay, but maybe you wake up at 3 a.m. and you're up for the rest of the night. Or maybe you wake up many times during the night without any rhyme or reason. And it's this sleep fragmentation, or the waking multiple times through the night, which is one of the most common sleep disorders in people with Parkinson's. Now, what's very important is to figure out the cause of why somebody is waking up multiple times during the night, so we know how to choose the right solution to fix the problem. Now, the different causes of insomnia in people with Parkinson's can include just bothersome Parkinson's symptoms, depression and anxiety, overactive bladder, some medications that can have stimulating effects like selegiline and caffeine, the environment or lifestyle. Maybe the bed partner snores, maybe there's dogs jumping on the bed in the middle of the night. Daytime napping can cause insomnia, and then finally circadian rhythm disturbances or problems with your own body clock. So it's important for you to make sure you talk to your doctor, make sure if your doctor's not asking that you tell. In order to know whether or not there's a sleep problem, we may have to interview both the patient as well as their caregiver. Questions we might ask if we want to figure out if you're having trouble sleeping is, what time do you go to bed? How long does it take you to fall asleep? Are you waking up frequently during the night, and are you able to tell why? How many hours of sleep do you get? Do you snore? Do you act out your dreams or move around a lot in your sleep? Are you sleepy during the day? Are you taking anything for sleep, any type of sleeping pill? And then what are your other medications that you take? So this will be all important information to figure out what could be leading to insomnia. So one of the causes of insomnia is nocturnal hypokinesia, and that's just the technical term for bothersome Parkinson's symptoms during the night. So a patient with Parkinson's may be able to fall asleep just fine, but then 2 to 3 hours later might feel physically uncomfortable. Sometimes the tremor will start recurring, and it's hard to fall asleep if your body's shaking. And sometimes a person, if they're awake, will get up to use the bathroom as opposed to the other way around. It wasn't an overactive bladder that woke you up. Rather, it's, well, I'm awake anyway. I might as well use the restroom just in case. So it's always important to make that distinction. With the nocturnal hypokinesia, it's usually due to wearing off. So in other words, the medications you've taken for Parkinson's earlier in the day are completely out of your system. So you're very low on dopamine. It's hard to turn over in bed. You just can't get comfortable. It's hard to get out of bed. You might feel restless. You might have leg cramps. And you can, yes, indeed, just experience sort of full body pain from a low dopamine state. So the way we would treat insomnia, if it's from the nocturnal hypokinesia, is by treating the Parkinson's symptoms. You know, a sleeping pill won't fix this problem. There's long-acting preparations of the carbidopa-levodopa called the carbilevo CR or ER if it's generic. Sometimes taking a dose of regular carbilevo kind of crushed up to kick in faster might reduce those nighttime Parkinson's symptoms and let you fall asleep. The dopamine agonists like rotigotine or ropinirole or pramipexole are long-acting medications, and they should take you through the night to control your Parkinson's symptoms till morning. Now, interestingly, patients with either deep brain stimulation or patients who might have the Duopa infusion pump don't wear off at night because those treatments are just always, you know, even keel. They're not going up and down like medication dosing can, and many times sleep improves as an added benefit of those therapies which are used to treat the motor symptoms of Parkinson's. And there's 2 new medications, inhaled levodopa and the sublingual or under the tongue apomorphine that absorb very quickly and can give you that quick kicking in and on state to help you fall asleep at night. So other causes of insomnia in Parkinson's is the poor sleep hygiene, mood disorders like anxiety and depression, the circadian rhythm or body clock problems, frequent urination, and then finally medications. Now, poor sleep hygiene means that are you somebody who's napping during the day and then you're all slept out when it comes to the nighttime? So in order to practice good sleep hygiene, you want to keep a regular bedtime and a regular wake time. Because if you go to bed several hours later and wake up at a different time, you're essentially giving yourself jet lag, like you've traveled to a different part of the world. So even if your schedule doesn't demand it, try to keep a very consistent sleep and wake time. Have a bedtime routine. Maybe it's I brush my teeth, I hang up my clothes, I read a little bit of a book. Because that nighttime routine, if it's very consistent, it's telling your brain and your body, yep, this is nighttime, I'm getting ready for bed, I'm getting ready to fall asleep. Avoid caffeine in the evening. Even if by the late afternoon you want to not be consuming caffeinated beverages. And actually avoid alcohol late in the evening, because alcohol will help you fall asleep, but then a couple hours later you'll wake up as it wears off. So it actually ruins the quality of sleep. Having a heavy meal before you go to bed makes it hard to sleep well. Avoiding bright lights or screens, especially checking email, checking Facebook. If you do that too close to bedtime, it actually stimulates you and wakes you up. Limit daytime napping to not more than a 30-minute power nap, and don't do that too late in the day. The falling asleep watching TV in the evening can just really ruin your nighttime sleep. And then regular exercise is just so good for relaxing and restoring and giving good quality of sleep, provided you don't do it too late in the day. Because exercising before bedtime might give you that second wind that'll keep you up much later than you had intended to. So stimulus control. So that is, how do you remedy the situation if you're not falling asleep? What should you do? Should you get nervous and watch the clock? And the answer is, absolutely not. So if you've been in bed, you're laying there, 30 minutes have passed, and you're not falling asleep, just don't stay there. Because otherwise your mind starts to associate, oh, laying in bed is this place that I'm staying awake and it's making me nervous. So you can't do that. You have to get out of bed and do something else. So maybe turn on the television or read a book. Do something that's maybe a little dull or boring to make you drowsy. And then when you start to feel drowsy or sleepy, that's when you want to climb back into bed and see if you can then promptly fall asleep. Excuse me. So if the reason for insomnia is depression or anxiety, those conditions need to be treated as such. If a person is experiencing depression, there are numerous different antidepressants on the market, and one of them that comes to mind is mirtazapine. It actually makes a person more drowsy, so it can work if a person is having sleep disorders as well as having depression. Excuse me. And then trazodone is another antidepressant that's oftentimes used as a sleeping medication. There's a category of medications called the SSRIs, or the selective serotonin reuptake inhibitors. Examples could be escitalopram or sertraline or Paxil, for example. Those aren't necessarily sedating, but if you treat the mood disorder and treat the depression, the sleep disturbance can then normalize and things can fall back into place. And then finally, benzodiazepines can be used for treating both anxiety and sleep problems. And some examples of that category is clonazepam and lorazepam. If insomnia is being caused by stimulating medications, you might need to stop them or perhaps move them earlier in the day. So selegiline is a Parkinson medication that has amphetamine metabolites. You typically just want to dose it in the morning. The same with amantadine, dosing that earlier in the day. Of course, we had already mentioned no caffeine later in the day. And then Aricept, also called donepezil, is a memory medication that sometimes worsens sleep, so then one should take it in the morning rather than at bedtime. So we already mentioned, avoid exercise later in the day, ensure a quiet sleep environment. So if your spouse is snoring or somebody has the TV on too loud, do what you can to make the noise the least disturbing. Maybe you have to wear earplugs. And then if overactive bladder is causing a person to wake up, there's medications to treat overactive bladder. There is behavioral management for overactive bladder, like don't drink a lot of liquids after 6 p.m. or even elevating the head of the bed. Then that you don't have as high of a blood pressure as when you lay flat. And then there's less of a signal for the kidneys to make urine to bring the blood pressure down. So those are all things you can do to address overactive bladder. So if we've ruled out all these other causes for insomnia and we're looking at, well, this is just a sleep disorder, we want to use a sleep medication, there's numerous options to choose from. So there's what are called the non-benzodiazepine sleep agents. And just to name a few of them, Ambien, Sonata, Lunesta, Roserum. Medications like Ambien, we're a little bit concerned, can sometimes cause nighttime confusion, sleepwalking, and might be associated with increased risk of falling in the older age group. Some of the older antidepressants like the trazodone, amitriptyline, and doxepin can work very well for helping someone to both fall asleep and stay asleep, and they're not habit forming and less likely to cause issues with falling or nighttime confusion. And back again to the benzodiazepines, which also can help to treat anxiety, like clonazepam and lorazepam. So any of the medication ending in PAM is in this category. So this category of medications, though, can be habit forming, that people start to depend on them to fall asleep, and a tolerance can develop, which means you need a higher and higher dose to have the same effect. And then also with this drug category, it's associated with increasing risk of falling in people over age 70. So many times it'll even pop up as a warning. As a physician, when we try to prescribe this category of medication in a certain age group, it just says, warning, do not use this after a certain age because it can increase risk of fall. Now, there's always exceptions to the rules. So there are some situations when, yes, a benzodiazepine might be the most appropriate medication for somebody, and regardless of what the age group is. The antipsychotic medication called quetiapine can be helpful for sleep, and it also can address hallucinations if that happens to be a concurrent problem. There's over-the-counter sleep aids. Diphenhydramine is Benadryl or Sominex, Unisom. So it's an antihistamine that causes drowsiness, and that's frequently used as a sleep medication. The negative effects of that are potentially dry mouth, aggravating constipation, sometimes can cause urine retention. And then for some, they just kind of still feel drowsy or have kind of this hangover feeling in the morning. The effects just linger too long, and it can sometimes cause nighttime confusion. And a natural supplement called melatonin can be an excellent sleep aid. Interestingly, people with Parkinson's, or just as we get older, we start to run low in melatonin, which is a naturally occurring neurochemical. So a supplement can help the quality of sleep, as well as a natural substance called valerian root. If we wanted to look at non-medication ways to help insomnia. There's cognitive behavioral therapy, which is talk therapy, that helps you work through what issues might be keeping you awake. And then mindfulness, which Dawn will be speaking to us about a little bit later this evening. So don't let this be your doctor. I like this cartoon. So the doctor's saying insomnia is very common. Try not to lose any sleep over it. So don't be dismissed when you're expressing concern about your sleep problem. Make sure that your doctor takes it seriously and helps you work through it so that we can improve your quality of life. Now, the reason why you shouldn't dismiss insomnia is because there are other health implications if we sleep poorly. Poor sleep can be associated with weight gain and obesity. In part, I think we tend to nibble more if we're very tired and trying not to fall asleep. Also, when we're sleep deprived, our body makes more cortisol, which encourages weight gain. Poor sleep can cause high blood pressure, which can increase the risk of heart disease. We can see an increased risk of diabetes. Our immune system doesn't function as well when we're sleep deprived. And then finally, from a psychological perspective, poor sleep will oftentimes translate to depression and anxiety. It can be a cause rather than a result. Lower cognitive performance and slow reaction time. Okay, so moving away from insomnia to other sleep disorders in people with Parkinson's, this is the sleep disorder I find the most interesting. It's called the REM behavior disorder. So it's acting out dreams. So if you remember, REM sleep stands for the rapid eye movement sleep or is dream sleep. So in the REM behavior disorder, people are acting out dreams. They might be talking in their sleep or shouting, moving violently. And if somebody's dreaming that, you know, they're kicking and punching somebody, they could potentially do those activities in sleep. I had a patient one time who dreamt they jumped into a swimming pool and they flipped themselves out of bed. So having these violent movements during sleep can put you at risk for injury. So the dreams usually are quite vivid to produce this type of movement. Again, being attacked by somebody or being attacked or chased by an animal. The REM behavior disorder tends to occur later in the evening because remember, we have more dream sleep in the second half of the night or the later third of the evening. So more of the dream and acting behavior comes out like 2 in the morning, 3 in the morning, and so forth. And then it tends to occur in clusters. You might have some days it doesn't happen, and then you might go days or weeks in a row with these repeated events. So this REM behavior disorder is exceedingly common in people with Parkinson's. 25 to 50% of patients will act out their dreams. And many times when we ask the question, do you act out your dreams? It helps us to clinch the diagnosis of Parkinson's. So the sleep disorder happens because those Lewy bodies, you know, that pathology in Parkinson's is down in the area of the brainstem, in the area that should paralyze you when you're sleeping. So when that area doesn't work, you can act out the dreams and you're not paralyzed and still in the dream state like somebody who doesn't have Parkinson's. Now, fortunately, REM behavior disorder is very treatable. There's the natural supplement melatonin that I talked about for treating insomnia, also can work very well for stopping the REM behavior disorder or dream and acting behavior. A starting dose can be as low as 1 to 3 milligrams, or we can take it as high as 12 milligrams. But always start low and work your way up because less is better when it comes to the medication. And then that prescription clonazepam that we had talked about for anxiety or insomnia is also a good treatment for REM behavior disorder if needed. So other possible treatment options, pramipexole or levodopa, which is used to treat the Parkinson's, can sometimes help the REM behavior disorder. Memory medications like donepezil and galantamine will sometimes reduce the REM behavior disorder, as well as the antipsychotics clozapine and quetiapine. Now, general measures is, you know, creating a protected environment. So if we look at this picture with this gentleman, he's acting on his dreams. We see the nightstand right next to the bed. Well, if he fell out of bed, he could hit his head on the nightstand and get a cut, you know, or he could get his arm caught in that beautiful headboard that's very intricate, but you could get your arm stuck and be injured that way. So you want to have nothing by the bedside. So if you fell out of bed, you're just landing on the soft carpet, you know, no sharp headboard, you know, anything that you'd be injured if you're moving around. And then sometimes for the bed partner, they may have to sleep in separate beds or having a king size bed with more room and putting a body pillow between the person with REM behavior disorder and the bed partner. Now, also, if you're ever hospitalized and you have REM behavior disorder, you need to tell the nurses and the care team that, yes, I do act out my dreams. I might yell in my sleep, because if they're not aware of that happening, they would think you're maybe confused or combative, and you might get unnecessarily medicated if you're in the hospital. So just make sure people are aware. Or if you're ever on vacation sleeping over at another relative's house. You have to let them know, yep, I have this sleep disorder. Don't be frightened. It's nothing serious. Now, sometimes other sleep medications or other medications in general can aggravate rather than help the REM behavior disorder. So the antidepressants, venlafaxine or mirtazapine, caffeine, and so forth, SSRI, some of those will be aggravators of REM behavior disorder, and reducing or taking away a medication can solve the problem rather than adding a medication. Now, the diagnosis of REM behavior disorder can be made usually just with a good sleep history. If the bed partner is able to say, yep, in the second half of the night, they're acting out dreams, yelling, punching, kicking, pretty likely to be the REM behavior and not necessarily anything else. So a sleep study oftentimes is not needed in this situation. All right, some interesting facts about the REM behavior disorder. So during the dream and acting behavior, a patient with Parkinson's, despite being off medications, can move quite well. They may not have a tremor. Their voice can be loud when maybe they're very soft and quiet during the day. And sometimes the more severely affected side moves even better. So it's fascinating. And the question is why? Well, maybe this dream and acting movement is bypassing the area of the brain called the basal ganglia that's deficient in dopamine, or there's motor movement being driven through a different pathway in the brain. So it's an interesting concept of, is there anything about this REM behavior disorder pathway that we could harness to help somebody move better in the wake state? So some thoughts of perhaps deep brain stimulation targeting a particular area of the brain could be helpful, but it's so in the infancy of research that nowhere near being a treatment for people with Parkinson's. This is more of an interesting fact than a possible treatment. Okay, moving on to restless leg syndrome, another very common sleep disorder in people with Parkinson's. Up to 20% of folks with PD will also have restless legs. Restless legs presents with this urge to move the legs. I can't get them comfortable. I got to get up. I have to walk around. And that discomfort is relieved if you do stand up and move around. The restless legs is typically worse later in the day or when you finally lay down in bed to rest. And it might associate with your medications wearing off when your dopamine levels run low. Restless leg syndrome is not a precursor to Parkinson's, so there are many, many people out there in the world who have restless leg syndrome who will never develop Parkinson's. So it is its own condition by itself. Again, people with restless legs might say, I can't get comfortable, I can't fall asleep, I feel antsy, my legs are itchy or they're tingly. There's a creepy crawly sensation on my legs. I just dread going to bed because I know my legs are going to bother me, or I don't want to go to the movie, I don't want to go to the theater because I can't sit still, or I can't either fly on the plane or ride in the car for a long period of time because I know my legs are just going to drive me nuts. So if somebody has restless legs, one of the things we should look for, is there some other underlying cause? Like iron deficiency can be a cause for restless legs, as can minor kidney disease. So simple blood work is oftentimes done if you have restless legs to make sure there's not some other driver of that leg discomfort. And then reviewing medications, because medications can do good things as well as bad things. So some medications like stimulants or the SSRI antidepressants can aggravate restless legs, and sometimes you have to choose a different medication to treat depression so as to not aggravate restless legs. Now, treating restless legs will depend on the cause. If it's end of dose wearing off, just like the nocturnal hypokinesia, we'll treat the Parkinson's to treat the restless legs. If it's not the Parkinson's wearing off, then medications that are used specifically for restless legs can include clonazepam and gabapentin, pregabalin, and then interestingly, the Parkinson medications like the dopamine agonists and the carbidopa levodopa. In severe cases of restless legs, when the typical medications aren't working, we sometimes do have to go to the opiate medications like morphine or oxycodone and so forth, but we rarely want to go to that medication category because of the addiction potential. Now, you can do mechanical or behavioral things to help the restless legs, such as stretching before bed, taking a warm bath. There's a vibrating pad that you can put under your legs, and then there's the SCDs, which are the sequential compression devices. And those are the pumpers that go on your legs when you're in the hospital to keep the leg circulation going, that sometimes can alleviate some of the symptoms of restless legs. Now, the differential diagnosis, that's the list of the possibilities of what else could this be if it's not restless legs. So again, end of dose wearing off. It can be drug-induced dyskinesias. So if you've ever seen People with Parkinson's, when their medication dose is too high and you have that kind of wiggly movement. So leg movements like that could be a dyskinesia. Now, how you can tell the difference is in restless legs, you feel uncomfortable. You feel like you need to move the legs around, whereas in dyskinesias, the legs are just moving on their own. And off dystonia, so patients with Parkinson's can wake up with their toes curling or their feet pointing with the legs cramping, and that can be dystonia or muscle cramping from low dopamine levels. And then anxiety or the inner tremor, inner shakiness that goes with wearing off. And then some people with Parkinson's do have kind of a prickly, tingly sensation in their feet that isn't restless legs. So a good history on the part of your physician will help to sort that out. Now, another sleep disorder akin to the restless legs is the periodic limb movements of sleep. And that's where the legs just kind of kick and flip, and they move on their own without any sensation of being uncomfortable. And it's usually a twitch or two, not repeated movements. And a person whose legs are twitching like this are not aware that it happens. Sometimes the bed partner might get a little kick, but the person experiencing this doesn't necessarily feel it. It can disrupt sleep because it will wake you up partially. So you'll go from a deep sleep to a light sleep, but you won't be completely awake, so you're not realizing that it's disrupting sleep. It sometimes is only identified in a sleep study. The periodic limb movements of sleep oftentimes occurs along with restless legs. They do go together, and we do the same treatment for this condition as we do for restless legs. Nocturnal myoclonus is a single, jerk of the full body that happens, and it's a normal reaction when we just doze off and fall asleep. So if you recall ever seeing people in a lecture or in school when they doze off and their whole body jumps. So it's very common, it's normal, it's physiological. It tends to be aggravated a little bit by the Parkinson medications and by some antidepressants, so that might make it more frequent, but it's benign, it's not harmful, it's nothing to be worried about. It certainly isn't a seizure. It's nothing of concern. It just can sometimes, again, be a little bit annoying for the bed partner or for the person who gets the body jerk if it wakes them up. Vivid dreams is a possible precursor to hallucinations during the day. So people who have these vivid dreams are more likely to have cognitive impairment. They're more likely to have more advanced Parkinson's and be on more medications or higher dosages of medications. And with vivid dreams, it's not uncommon for a person with Parkinson's to wake up confused, or I describe it as being half in the dream, half in the wake state, and it can take a few minutes to clear completely. So waking disoriented is not uncommon. So to treat this problem, reducing the dosages of medications later in the evening can be helpful. Sometimes adding an atypical neuroleptic medication like quetiapine can calm those vivid dreams and the confusion during the night. So obstructive sleep apnea is another sleep disorder very common in people with Parkinson's. At least 20%, if not more, are afflicted with sleep apnea. So sleep apnea is defined as just an absence of or a reduction in airflow through the air passages during sleep. So the symptoms might include loud snoring or waking up or gasping or choking, and just if you're watching somebody, they stop breathing for a period of time and then gasp and start breathing again. Sometimes the only way to know that somebody has sleep apnea is they're just very, very tired and have extreme fatigue during the day. Sometimes mood disorders. You could be depressed because your sleep quality is bad. Some have chronic headaches. And then sometimes getting up to use the bathroom can be a symptom of the sleep apnea waking you up and not just overactive bladder. Many times in people with Parkinson's, they can be thin, long neck. You don't have to have the body habitus that we think of for people who usually have sleep apnea, which is overweight, very short neck, kind of like the offensive linemen on the Packers or the Bears. So this is a picture of the airway. So on the left, we see the palate is in place where it needs to, the air is flowing through. And in people with obstructive sleep apnea, on the second picture off to the right, the soft palate just kind of collapses and closes off the airway, and that's what causes the breathing to stop and that gasping and choking sensation. So how do you diagnose sleep apnea? Well, you might definitely indeed need the sleep study. So this is a diagram of what it looks like to have a sleep study. So in a sleep study, a person will be asleep in the sleep lab in the hospital. You have the belts with sensors that are around your chest that can measure, is your chest moving up and down? there's a sensor in your nostrils that's measuring, is the air flowing in and out, or is there no airflow, or is that passage blocked? There are electrodes on the head that are measuring the EEG or the brainwave patterns to determine, are you awake, are you light sleep, deep sleep, or in the REM dream sleep? There's a pulse ox on the fingertip that's measuring your oxygen levels to look if your oxygen is dropping when you're stopping breathing. So fortunately, sleep apnea is very, very treatable. The most common treatment is the CPAP machine, which allows air to be blown in under higher pressure. There can be dental or oral appliances that just open the airway and prevent that soft palate from collapsing. Sometimes we can treat sleep apnea just by reducing nasal obstruction. If somebody has large, polyps in the nose, that can be causing the airway to be blocked. Weight loss can be very helpful for sleep apnea, as well as positional therapy. And it may be somebody obstructs only when they're lying on their back. We make them always sleep on their side and their airway stays open. So the risk of leaving sleep apnea untreated is it can cause high blood pressure, weight gain, headache, memory loss, depression, and heart disease, just like the insomnia and poor quality sleep. There's a picture of the oral appliance to open the airway. And just another picture of the CPAP, the continuous positive airway pressure. So it's an air oxygen mask that's under pressure connected to a little pump, and it's just forcing the air in, and it opens that soft palate, which has collapsed down. So an interesting fact with sleep apnea, when they've done studies of people with bad sleep apnea, and they've done cognitive testing, some people who sleep so poorly can score in a severely impaired range that might look like they have Alzheimer's disease. So poor quality sleep can have hugely negative effects on the cognitive function. And one of the questions is why? So is it just the sleep deprivation that you lose your focus, you can't concentrate, or is it the low oxygen levels is actually causing some brain damage to the nerve cells? Well, fortunately, in these studies, when people were treated successfully with CPAP or other methods that resolves the sleep apnea, the cognitive function seems to improve back up to the normal range. That argues against it being damage of nerve cells from lack of oxygen, more just the negative consequences of the chronic sleep deprivation. So I'm going to switch gears. I just went through all the nighttime sleep disorders in people with Parkinson's, and now I'm going to talk about the daytime sleep disorders in people with Parkinson's. So excessive daytime sleepiness. So that kind of looks like me at the end of a day. You're just worn out and you cannot avoid falling asleep. So excessive daytime sleepiness is exceedingly common in people with Parkinson's. And just like insomnia, we have to define the cause of why somebody's sleepy to figure out the best solution. So is it just poor quality of sleep at night? Or is it medications that can cause drowsiness? Or is it just the Parkinson? Because Parkinson's disease in and of itself can cause sleepiness and fatigue. So who's at risk of being excessively sleepy? Well, those who are more advanced in age, people who have more advanced Parkinson's for more years or longer duration of time, people on higher dosages of the Parkinson medications, and then the medication category of the dopamine agonists like the pramipexole or ropinirole are the bigger culprits for causing excessive sleepiness. And now many times the sleepy drowsiness also correlates with cognitive decline and hallucinations, but that also goes along with having more advanced Parkinson's and a much longer duration of the disease. Now, deciding on whether or not to treat excessive sleepiness depends on the severity. So if somebody's just a little drowsy at night, 7 p.m. watching television, that's not too out of the norm. But if somebody's falling asleep at lunchtime or having trouble staying awake at work, or maybe at risk of driving, you certainly, or pardon me, at risk of falling asleep when driving, you certainly do need to treat. So treatment methods can be reducing or lowering the dose, or even discontinuing the potentially offending drug like the dopamine agonist. Sometimes using a stimulant like medications called Provigil or Nuvigil, or even caffeine can help to keep somebody awake. Increasing physical activity. So if you feel drowsy, get up and walk around and do something rather than doing a sedentary activity. And sometimes with excessive sleepiness, that short nap can re-energize and just give you more energy and power for the rest of the day. There's one study that looked at bright light therapy versus, so this was a randomized study that looked at bright light versus a dim light. And if a person was treated for an hour in the morning and an hour in the afternoon, what was the benefit? And it did show a significant improvement in the severity of sleepiness through what's called the Epworth Sleepiness Scale. So people with the bright light improved by 4 points, whereas those that just got the dim light improved by less than 2 points. So light therapy can be helpful for excessive sleepiness. Now, in excessive sleepiness, I just want to have people aware of the sleep attacks. And this was a relatively new concept in the field of Parkinson's in the late 90s. And a quote in the literature said, excessive sleepiness or sleep attacks is an event of overwhelming sleepiness that occurs without warning, or it occurs with a prodrome that's sufficiently short or overpowering to prevent the patient from taking an appropriate protective measure. So you're suddenly falling asleep. You can't say, oh, I'm getting a little bit drowsy. Maybe I should lay down and take a nap. It just happens too quickly. Motor vehicle accidents have been associated with these sleep attacks. And when it was first reported in the literature by Dr. Froedtert and colleagues in 1999, they realized there was a strong correlation with the dopamine agonist pramipexole and ropinirole. Now, finally, when we're thinking about excessive sleepiness, we also have to make the distinction between fatigue, apathy, and depression. So sleepiness is I'm going to doze off and fall asleep, whereas fatigue is my body is physically tired. I don't have the same amount of stamina. And apathy is kind of a loss of motivation. A person's not driven to do and accomplish things without needing a lot of external, encouragement. And then, of course, the mood disorder depression of people can have fatigue and just feel very tired, and that's not the same as just excessive sleepiness. So a good history from your physician will help to sort that out. How do we evaluate sleep disturbances? Sleep diaries can be helpful, sleep questionnaires, and then, of course, the sleep study in the hospital. And this is just an example of the Epworth Sleepiness Scale. It's a questionnaire that asks you how likely are you to fall asleep. If you're watching television, if you're sitting in a public place, if you're talking to somebody, if you're in the car, stopped at a traffic light, and a score of 0 is like I would never fall asleep in that situation. A score of 3 is I'd be highly likely to doze off in this situation. So we go through the questionnaire, we add up the score, and a score over 10 is an indication that there's some excessive sleepiness. And we oftentimes have to use this questionnaire as a screening tool in order to order a sleep study. Otherwise, the insurance companies may not want to cover it. So finally, in summary, sleep disorders are common in people with Parkinson's disease, and they have many different causes. Sleep disorders can come from a side effect of medications. The difficulty sleeping can be just from insomnia, and that could be physical discomfort from the Parkinson's symptoms. It can be overactive bladder. It can once again be medication side effects. Sleep disorders can come from depression, anxiety, can come from restless leg syndrome, sleep apnea, REM behavior disorder. So we do have to determine what is the cause of the sleep disorder in order to know how best to treat it. And we have to treat sleep disorders because poor quality of sleep translates to poor quality of life and just a decline overall in a person's cognitive and physical function. So that is actually all I have. So thank you very much.
Thank you so much, Dr. Blindauer. We so appreciate your time and your expertise about a subject that is so important and affects so many people with Parkinson's. So thank you so much. So everyone, before we go on to back to Dawn, our next speaker, I just wanted to quickly talk about our wonderful sponsors today. And I also just want to give a quick reminder, so please keep submitting your questions in the Q&A on the black banner on the bottom of your screen. We're getting some great questions, so we really appreciate that. So please keep submitting those. So before we move on to our next speaker, I'd like to thank our generous sponsors of today's program: Kyowa Kirin, Supernus, Synovian, Accorda, Amneal, and UCB. Their support helps us keep today's program and others free and available to all. And something else I'd like to point out. So this is our virtual exhibit hall. So for more information about these companies and the resources that they offer the PD community, including detailed product information, please visit our virtual exhibit hall located here at this link. So it's parkinson.org/Greater Illinois/chapter supporters. When you visit this page, all you'll need to do is click on the logos of those sponsors and it'll bring you up that detailed information. So a big thank you to them again. And now I would love to reintroduce Dawn, our mindfulness expert. So we're going to bring Dawn on. And if we have any issues with bringing her video, we're just going to hear her voice and continue the presentation that way. So just give us a moment. All right, hold on one moment, everyone. Sometimes we do have these technical issues, but hold on one moment. Dawn, are you there?
I am here.
Great. Oh, good.
Okay, there I am.
Yay, awesome. So nice to see your face.
Okay,
Thank you
well.
so much. Thank you,
Yes.
Dawn. And I'm going to let you take it away.
All right, thank you. Thank you, Jessica, and thanks to the Parkinson's Foundation for having me here today so that I can share my love and passion for mindfulness and mindful exercises. I just want to start out by kind of giving you guys a good idea of how I got into mindfulness, because it probably relates a little bit to you. Several years back, I got pretty ill, and I didn't know what was wrong. And 7 to 8 months later, I found out that I did have Lyme disease, and I did get treated. But those months pre-diagnosis can be pretty crazy. And, at that time I changed my diet and started exercising, doing whatever I could. And I did find mindfulness, and that did really help with a lot of my symptoms. And I still use it today, and I'm healthy, and I still use it. So I just wanted to bring that in. So today we're going to be talking about mindfulness, and we're going to do some exercises to help with sleep issues. I'm going to start out to define mindfulness for those people that just don't really know what it is. So there's really 3 points that I want to make on that. The first point is that to be mindful, you need to be focusing on the present moment. So you're not thinking of the past, you're not thinking of future worries, you're thinking of just this moment. The other part of it is that you're going to be monitoring your thoughts. So you're going to be able to notice if you're in the present moment or if your mind is wandering. And that, a lot of people might go, well, that's crazy. I already monitor my thoughts. But we have so many thoughts going on in our head. We have visualization that comes in through, what we see physically, what we smell, what we hear, and then we're talking to people, and all this information is coming in, and we're thinking about past thoughts and future worries. So monitoring your thoughts is really something that you do have to do while doing mindfulness. And the last point that I want to make on that is that you also want to bring in non-judgment, and that's just basically, being kind to yourself, being okay with letting your mind wander. Mindfulness is a skill that you build up, so sometimes it doesn't happen right away. So it's something that you have to work on, and the skill that you build on, so that you have another tool for your toolbox in helping you with your illness. So we're going to talk about 3 different exercises today that are mindful exercises. We're going to do a breathing exercise, we're going to do a meditation exercise, and we're going to do a visualization exercise. So we'll start out with the breathing exercise. And with this, we're going to just imagine that you're having some sleep issues. Maybe you wake up in the middle of the night, and you can't go back to sleep for whatever issue. Maybe you're having some pain or some sensations or some worry, but you're going to just focus on the breath. So You could put your hand on your chest if you wanted to while you're laying in bed. You don't have to, but it just kind of helps you focus. So you're focusing on that breath. So you would just start noticing your breath as you inhale and exhale at a natural pace for whatever you're doing, noticing the breath as it goes in, noticing it as it leaves your body. So that you can do. It's a good start. And the breath is used in lots of meditations as a focal point so that you don't get lost in your meditation or lost in your thoughts. And so, you know, focusing on the breath is always the very first thing that you can use as a focal point. Now, in most cases, you're probably going to be having issues that aren't going to go away with just focusing on the breath. So we're going to focus now on maybe a deeper breath. So after you do that for a little bit, you can move on down, maybe putting your hand on your abdomen diaphragm area. And we're going to do some diaphragmic breathing, which is deeper breathing. It's a natural breathing that we do when we're sleeping, and it's very relaxing. So it's not that I'm asking you to take in deep breaths, and we don't want you to hyperventilate or anything like that. So you're just still doing a natural breath and noticing as your abdomen area expands and contracts as you're breathing. And you're gonna notice how that is relaxing your body. Now, the thing you need to know about diaphragm breathing, or breathing from your diaphragm, is that it actually is bringing in a little bit more oxygen to your body, and it relaxes, so that oxygen kind of relaxes the muscles, and a lot of pain is caused by tight and tense muscles. So you're going to be working on releasing any issues that you have with pain or sensations with this kind of breathing. And it calms your body. And if just focusing on it isn't enough, you can also, maybe as you inhale, you could count, inhaling 1, exhaling 2, something to that effect, to really get the most out of that breathing exercise. So I want to move on to our next exercise, which is more of a meditation exercise. We call it the body scan meditation. It's very popular with people that have sleep issues. If you come to one of my meditations on site, you know, we're not wanting you to fall asleep, but in the situation where we're talking today, you know, you're having sleep issues or pain with sleep or other sleep issues, you do want to relax. This is about relaxing the body. So the body scan starts with focusing on one part of your body. So you can start at the top of your head, or you can start at your feet. Today, as an example, we're going to start at our feet, and we're going to focus on a part of the body that maybe isn't giving us so much trouble. So, you know, you wouldn't want to focus right off the bat on maybe where your pain is coming from. So we're going to focus on something like the big toe. So the big toe is kind of a part of our body that we don't really notice all the time. And we're putting the focus on that big toe. So that means that we're shining the flashlight of focus onto it, noticing sensations, noticing if it's hot or cold, noticing the blanket that's rubbing on your big toe as you're laying in your bed. And you're going to notice it. And the other part you're going to do with this is notice if there's any tight muscles or tension in that part of your body. So in your big toe, you probably wouldn't, but you might. So you would try to release any tension from that part of your body. And something to remember, because some people have a hard time with that idea of just saying releasing tension, but just telling your body that you want to relax that muscle, your body listens to that and will automatically release any tension that you have. But you could also stretch that part of your body, whatever you want to do, but you're moving up your body. So you would then move up to the next body part, maybe the top of the foot or the ankle, and keep releasing the tension. And as you're doing this, your body just relaxes so much that you probably will just fall asleep. You can go up one leg and then start at the bottom of the other leg and work your way up. You probably won't get all the way up your body before you fall asleep, or that's the hope anyway. But either way, this meditation is great because you're automatically relaxing that part of your body. Your body is relaxing. Even if you're not falling asleep, it will relax you so that you are able to be aware of getting some rest. So we're going to move on then to the visualization exercise. Now, visualization is really a great tool for changing behavior. They've done some studies on visualization that have shown that if you have a very vivid visualization and you add in a really strong positive emotion, that it can actually change a visualization into a memory in your brain. And that's so exciting because you're kind of reprogramming your brain a little bit there. So today, because we're talking about sleep issues, I would say that we need to come up with a memory that we've already had of something from a time when we were the most comfortable and relaxed. Maybe a time when you were snuggling up with your mother as a child, or maybe when you were with your pet, or just being with a really fuzzy blanket in front of a fire or something like that. And you're going to bring that visualization into your head while you're laying in bed trying to fall asleep. And you're going to bring in, now you might have great emotional memories from this, or you might just have it as a memory and not really have a whole lot of emotion tied to it. So you can bring in emotion as well. So you want to bring in, imagining that time when you were felt the most loved, the most relaxed, just bringing in the idea of, I'm going to be at peace. I'm going to be at ease. My body is going to be relaxed. And you can even say those kind of phrases to yourself while you're doing this exercise. And that can take care of some of those other, again, you're taking the focus away from whatever the situation is that's causing you not to have good sleep, and you're turning it into a different focus. So that's why I really love visualization. And I'm hoping that would be a really good one for anyone out there as well that would have sleep issues. Those were our 3 topics, three exercises, and I hope one of them will help you in some way. Please feel free to reach out. If you have any questions, you can let me know. I'll probably have contact information that you can check out our website at www.dragonflymeditation.com for any questions that you have in the future. And again, I want to thank everyone for letting me come on today and share that passion with all of you.
Thank you so much, Dawn. We We appreciate it. I love hearing anything about mindfulness and meditation because it's something that I don't have a ton of knowledge about, but I know that it works. So thank you so much for sharing that information. So, and we will include all of these resources and all the information that we're talking today also in a follow-up email to everyone. So now we are going to invite Dr. Blindauer back, and we have gotten some great questions for both of our speakers, and I'm going to start the Q&A session right now. So Dr. Blindauer, my husband has PSP. Would he benefit from the same PD suggestions for better sleep? And maybe Dr. Blindauer, just kind of explain quickly what PSP is if our audience does not know.
Okay. So PSP is a condition that we put in the category of an atypical Parkinsonism, because there are different forms of Parkinson's disease, the very typical, and then what we call the Parkinson plus or the atypical. So how it differs is that the changes in the brain are a bit different on the microscope, as well as the symptoms that people experience. So in PSP, there's slowness of movement, sometimes tremor that looks like Parkinson's, but then individuals also have a much more profound problem with their balance, with speech, swallowing. So it has symptoms that go beyond what we see just with garden variety Parkinson's. So for sleep issues in PSP, we would try the same techniques, just like even treating some of the motor symptoms of PSP, we would use the same medications for Parkinson's disease. Now, sometimes they might not work as well since we're not treating garden variety Parkinson's, but they are the same tools that we would use in that situation.
Thank you, Doctor. Dawn, I've been experiencing more anxiety lately. Is there a specific mindfulness exercise you could recommend for my anxiety?
Okay. Well, pretty much any of these kind of exercises that I already worked out are great, because mindfulness, again, is focusing on the present, and anxiety usually has to do about worrying about something in the future. I also like to use counting with my meditations. We kind of talked about that a little bit with the breathing, but I've done different things like basic math issues to take our mind off of that, because we almost get caught in this little loop of worry, anxiety, pulling in. Last night I had some myself, and just something to break that in our brain to say, okay, we're going to move on to something else and focus on the present moment.
Great, thank you. Doctor, can electromagnetic interference from Fitbits or other devices disturb disturbances with persons with DBS? That is not really, sorry, let me restate.
Okay.
Can electromagnetic interference from Fitbits or other devices cause sleep disturbances with persons with DBS? Okay.
Wow, that's a very, very good question. So the electromagnetic signal that comes off of a Fitbit should not have enough strength to cause any interference with the function of a deep brain stimulator.
Okay.
And then therefore, if the deep brain stimulator is not malfunctioning, it shouldn't cause any issues with sleep.
Great, thank you. Doctor, another one for you. Can DBS cause sleep issues from overstimulation? Can lowering DBS settings at night help and then raise it back up in the day?
The only way I could see a deep brain stimulator potentially impairing the quality of sleep is if it produces dyskinesia. So in that situation only, there might be what we would call overstimulation and turning it down at night, having less dyskinesia, turning it up during the day, but that would actually be an extremely unusual situation. So most people with Parkinson's do not change their settings, daytime versus nighttime. So, okay. Yeah.
Great, thank you. Dawn, do you recommend any of these new sleep meditation apps? Our tech world right now.
There are a lot of different apps that you can get. And my thought is any meditation app is a good meditation app because you're working on your mindfulness. So I don't do any in particular. I know of people that will recommend one or over the other, but I really just am so passionate that people do the mindfulness and do the meditation that any of those apps are great.
Okay, great. And I know there's some there's one called Calm that I've heard of that many people seem to
So
gravitate.
many, yes.
Thank you. Doctor, what can you do about sleep disturbances and pain which wakes you up?
Okay. So waking up with pain, I think the main question then would be, what is the cause of pain? If it's the Parkinson's wearing off and pain from muscle cramping or tightening, then treating the Parkinson's in the evening. But then there also are other reasons to have pain at night. It could simply be arthritis, musculoskeletal injury. And if somebody's having arthritic pain that's impacting sleep, then you would need to treat the arthritic related pain. Oftentimes a sleeping pill would not be able to overcome the pain that you're experiencing. So you need to treat the pain to improve the quality of sleep. And then also, I think with what Dawn had mentioned, the mindfulness, relaxation, to help reduce the impact of the experience of pain that's also creating anxiety and keeping you awake.
Great, thank you. Doctor, another question for you. I don't know if there's an answer to this, but I'm curious. Please discuss ways to minimize sleep talking. Is there a way? I imagine it's from a bed partner. So.
Okay, so in the situation of REM behavior disorder, it might be manifesting simply as the sleep talking, as opposed to all of the violent punching, kicking. So if we think it might possibly be REM behavior disorder, we might be able to reduce the sleep talking with melatonin.
Oh, great.
Yeah.
Okay. And which is a natural.
Yep, the natural supplement that is frequently or commonly used for sleep.
Great, thank you. Dawn, I've tried to meditate before, but I had trouble concentrating. What do you recommend to help get me focused?
What I recommend is that you find a quiet place. You want to make it comfortable, and you want to do it in the same spot every day. So you want to make it into a habit. And you can just start out with just a couple of minutes. You don't have to jump into the 30 minutes, hour meditation right off the bat. You want to start out with what you're comfortable with, maybe 5 minutes, maybe 10 minutes, and focusing on something that's going to work for you. If it's not the breath, you can do some other, maybe a noise machine, focusing on a noise. Something else to just make that into a habit, then you can expand it over time.
Great, thank you. Doctor, I wake up most mornings with a headache at about 4 a.m. It also happens when I wake up after only a few hours of sleep. Do you have any advice for this?
Okay, so waking up with a headache could have a number of causes. So it could be obstructive sleep apnea that's associated with morning headaches. Sometimes it could be degenerative disc disease of the neck and sleep position that could cause a headache. So I think the best way to sort it out is to talk to your physician about the symptoms you're experiencing to help sort out if it might be sleep apnea, musculoskeletal issues, or even a neurological condition that could be causing a nocturnal or nighttime headache.
Okay, could be a lot of causes that you just have to get to the root to.
Exactly.
That makes sense. Another question. Dawn, if I'm having difficulty getting to sleep and I want to do a mindfulness meditation, do you recommend that I actually leave my bedroom and find another spot? Kind of like what we're talking about what Dr. Blindauer said with when you're having insomnia, maybe leave the room and then, go to a new spot. Do you recommend the same thing with meditation?
You wouldn't necessarily have to, but it might just, like, sometimes when I'm having issues, I might get up and go to the bathroom. I might get up and go get a drink of water, but then I usually go back to my bed because that's where I want to be rested. That's where I want my body to feel good. So then I'll come back and then I'll start some of these mindful exercises.
Great. Okay. Thank you. Doctor, any suggestions on how to deal with teeth clenching causing pain during sleep?
For teeth clenching, again, some people just have, it's called bruxism. So that's just teeth grinding. Sometimes it's just associated with tension and stress. There's many different ways to address it. A bite block from a dentist can oftentimes minimize the pain that's associated with teeth grinding, and there's no side effects with a bite block. Sometimes medications are needed, like muscle relaxants. If it's associated with wearing off in Parkinson's disease, it might be needing to treat the Parkinson's disease at night. So once again, it's what's the cause of the, the jaw clenching to figure out the best solution.
Great, thank you. Doctor, another one for you. Are there any sleep enhancing medication antagonists, maybe an agonist, that should not be taken with Parkinson medication?
Oh, your video momentarily froze and I didn't hear the question.
Oh, okay. Can you hear me now?
Yep.
Okay, are there any sleep enhancing medication? It says antagonist, but I'm wondering if that's agonist that should not be taken with Parkinson medications.
As far as all of the different medication options that I had mentioned, none of them would be contraindicated in Parkinson's. They wouldn't adversely interact. So I can think of dopamine blocking medications that we shouldn't use in Parkinson's, but those medications also should not be used just as a sleep aid. So everything that I had mentioned can be used safely in the setting of Parkinson's disease and people who are taking the usual Parkinson medication.
Okay, great, thank you. Doctor, I have another for you. How do I stop the acting out of vivid dreams in my sleep? I know that you had talked a little bit about this, but can you address that?
Okay, sure. To reiterate, so the acting out dreams is most likely the REM behavior disorder, and the treatment for that can be the natural supplement melatonin, the prescription medication clonazepam, and if those treatments don't work, then it's worth digging a little bit deeper to figure out, is the sleep disorder being potentially driven by the obstructive sleep apnea? So that would be the situation when the sleep study could be helpful. So if the usual treatments of the REM behavior disorder don't work, we need to dig deeper and to make sure we're not looking at unrecognized sleep apnea.
Great, thank you. Dawn, we have a question saying, what is loving kindness meditation?
Okay, loving kindness meditation. It's also known as metta. It is a form of compassion meditation, and this compassion meditation is basically they start out with loving and sending love and compassion to yourself, then moving out to your loved ones, then moving out to people maybe you don't know very, very well, maybe then moving out to people you're having issues with or don't understand or are upset with, and then moving out to the world. So it's just a way of sending unconditional love and kindness and compassion to those around you.
Great, thank you. We're going to actually, we have one more question, so we're going to end our Q&A after this question. And doctor, this one's for you. My mom wakes up quite often at night with frequent urges to urinate. This interrupts all of our sleep. Would love some insight. She has less urgency by the day and sleeps in the day quite a bit.
Okay. So as I had mentioned, with overactive bladder at night, sometimes it's a matter of drinking all of your fluids before 6 p.m. The more you drink in the evening, the more you'll have to get up to go to the bathroom. There are medications that can be helpful for reducing overactive bladder. And I had mentioned sometimes when we lie flat, our blood pressure can run a little bit higher, and then that gives the signal to the kidneys, let's get fluid out of the body to lower the blood pressure. So sometimes elevating the head of the bed can reduce the amount of trips that somebody has to take to the bathroom at night.
Okay, thank you so much.
Okay, you're welcome.
Well, and this concludes our Q&A session, and I want to thank Dr. Blindauer and Dawn for really just taking the time and answering all these questions. We can't thank you enough. So thank you so much for sharing your time and expertise with us today.
Yeah, it's my pleasure.
Thank you.
Yeah, my pleasure as well.
Thank you so much to the both of you. I just have one last comment here. So again, everyone, thank you to everyone for attending this program and joining us. We love having you here with us and sharing this information from our experts. And for up-to-date information about anything related to Parkinson's, please visit parkinson.org or call our wonderful specialists at 1-800-4PD-INFO. Thank you, everyone, and be healthy and safe. Have a good night.